Good morning, everyone, and welcome to another online webinar from the National Institute for Occupational Health. The National Institute for Occupational Health, the NIOH, is a specialized division of the National Health Laboratory Services, the NHLS, our mother body, and a sister institute of the National Institute of Communicable Diseases, that's the NICD. So welcome to this particular program, and our topic for today is communicable diseases in the workplace. And we've got quite a good set of speakers and presenters for you today. Our first speaker is Professor Mzimkhulu Zungu, who will start off the program. And you've seen the program on the pre-webinar slides. He's followed by Dr. Nonsi Gomba, who is also from the National Institute for Occupational Health. Professor Zungu is from is the head of one of our sections here at the National Institute for Occupational Health, as well as associated with the School of Health Systems and Public Health at the University of Pretoria. Dr. Nonsi Gomba is a part of our immunology and microbiology section here at the NIH. Our third speaker is Professor Cheryl McCrindle. She's emeritus professor at the School of Health Systems and Public Health at the University of Pretoria. And our final speaker is Professor Lucille Bloomberg. She's a consultant with the Right to Care South Africa and associated as an honorary position with the NICD, as well as the Universities of Pretoria and Stellenbosch. And with those brief introductions, I'm going to immediately hand over to Professor Zungu, who is going to share with us, if I can just quickly open that, his pre-recorded presentation, since he's not in office at the moment, but he's definitely logged in. So in a moment, I will share that with you.
Good morning, Program Director, Mr. Ashraf Rycliffe, my fellow speakers and colleagues. My name is Mzimkhulu Zungu from the National Institute for Occupational Health, a division of the National Health Laboratory Services, and the University of Pretoria School of Health Systems and Public Health. It is an honor to speak to you today, not to tell you about COVID-19 and where we are today, but to open the possibility that we can openly debate some of the pertinent issues around this topic. As we all can contribute meaningfully to this, I hope for engagement towards the end when we have questions. Yes, the objective of this short talk is to get us all to update ourselves on whether COVID-19 is still a hazard of concern in the workplace in particular. When discussing COVID-19, it is important to understand the terms displayed on the current slide. These terms became quite popular at the beginning of the COVID-19 pandemic, and they include terms such as endemic, outbreak, epidemic, and pandemic, which indicate how common a condition is at a point in time, relative to how common it it was at an earliest time. These categories are primarily based on how many cases of a condition there are compared with the expected number of cases over a given time and how far the cases have spread geographically, which is what we're going to touch on briefly. These definitions may seem straightforward, but applying them in evolving real-world situation is complicated. For example, HIV started in West Africa, was epidemic in Africa for decades, then was a pandemic by the late 20th century. But 2 decades into the 21st century, it is reasonable to say HIV is now endemic in some parts of the world, including our country. So we do need to ask and answer the question if COVID-19 is now endemic or still a pandemic. On the 5th of May 2023, the World Health Organization advised that COVID-19 was now an established and ongoing health issue, which no longer constituted a public health emergency of international concern. In this slide, we have some data related to some COVID-19 activity in different parts of the world. We can see that globally, to date, there has been at least 768 million cases or so, but there has been at least 6.9 million deaths associated with COVID. In Africa, there's been at least about 10 million cases with about 175,408 deaths. It is worrying, not just for me, but for all of us, I should think, in this talk, to see that most of those deaths came from South Africa. There could be a number of reasons why this is, but we can discuss that another day. Also worrying is the fact that, as we can see glaring, there is generally not adequate information about the workplace regards to infected workers, as well as workers who demised because of COVID-19. And as such, we need to work on our surveillance system, establishing them, maintaining them, making sure that they produce relevant data that can be used to make decisions about health and safety in the workplace. These 2 figures are just to show the trends in South Africa in particular. The one on the left shows us how cases have dropped over time, especially in the last 8 months to 12 months. The one on the right on your screen shows us about the deaths in South Africa in particular, that they have also dropped quite a bit. Now, whenever you're talking about issues related to the workplace, in particular health and safety, you need to be familiar with policies around such topics. So while there are many policies, it is important to remember that to guide us, we need to refer back to the International Labour Organization for the latest policy guidance. As shown in the slide, I have shown that currently the ILO is advising that we should continue to strengthen occupational safety and health measures in our workplaces, adapt work arrangements, prevent discrimination and exclusion, provide health access for all, and expand access to paid leave for workers. However, we cannot talk about policies and not mention the Department of Employment and Labor in South Africa. And for now, we can still rely on the following laws coming from the Department of Employment and Labor. 1, the Occupational Health and Safety Act and its regulations, the code of practice for managing exposure to SARS-CoV-2 in the workplace of 2022, as well as the notice on compensation for occupationally acquired coronavirus disease under COIDA. I'm not going to get into specifics of what each one of these policies say or laws, but we can read them on our own, and I'm sure we'll see that they do provide guidance on what needs to be done. Just in closing, I would like to say that based on the numbers that we've seen on COVID-19, based on the policies that I have referred to, in general information around COVID, that is, we can continue providing services. And these services going forward will have to include services that are based on risk assessment. And through that risk assessment, we should be able to also provide occupational health surveillance, including screening where appropriate related to COVID-19, and use such information from the risk assessment and the surveillance to educate and train our employees on appropriate interventions. We also have to provide vaccinations still. We have to provide appropriate referrals for treatment and care. We must not forget the complications that came with COVID-19, i.e. long COVID. It is still with us, and we must do more to protect workers and rehabilitate them. COVID-19 came with several issues, not just mental health issues, but also financial issues for workers. So programs such as employee health and wellness are of paramount importance. We must not forget to continue providing them where possible. And finally, the benefits associated with COVID-19 in the workplace will include submitting employees to COIDA, providing for appropriate leave according to company policies and in line with laws in South Africa, and also advise on other insurance benefits that employees might have access to, as well as providing employee accommodation in the workplace. In this short time that we have spoken, I know that there's much we could have touched on, but this was just an awareness to make sure that we can all start talking about the relevant issues and pertinent at this time and phase of the COVID-19 pandemic that we've just come from, and to be able to plan going forward. With that, I'd like to say, Ngiyabonga, thank you very much.
And that was Professor Mzimkhulu Zungu, the head of the HIV and TB unit here at the National Institute for Occupational Health, a specialized division of the NHLS, as well as associated with the School of Health Systems and Public Health at the University of Pretoria. Our next presenter is going to be presenting as well in a pre-recording, and that will be Dr. Nonsi Gomba, who's associated and part of our immunology and microbiology section here at the NIOH. Just a quick announcement before we start that presentation. Please put all your general admin comments in the chat box. Specific questions for the speakers and presenters in the question and answer box. Those questions will be answered live there for you. And the hand raising function is unfortunately not applicable for this particular webinar. So thank you for joining us on this particular topic of communicable diseases in the workplace. I am now going to ask my colleague to start the presentation for Dr. Nonsi Gomba. Thank you, Tabani.
Good morning, everyone. The title of my presentation today is Waterborne Infections and the Workplace. So the purpose of Sustainable Development Goal 6 also known as the water goal, as set by the United Nations in 2015, is to ensure the availability and sustainable management of water and sanitation for all by 2030, meaning we only have 7 years to achieve the 2030 agenda. It seems so far, but it's very near. My presentation today aims to remind us that we all have a role to play to achieve these SDGs, even if it is just by raising awareness on waterborne pathogen infections, how the exposures happen in workplaces, the conditions favoring microbial growth in premise plumbing systems, the complexity of the situation at hand with the focus on the built environment, and what can be done to manage these waterborne infections, and finally what NIOH is doing in this area. Please bear with me, this is a very broad topic and a crucial one too, given that blue is the new gold and I only have 10 minutes to speak. Anyway, water is essential for life but can also lead to illness when it is contaminated by disease-causing organisms. Waterborne infections are those infections resulting from the consumption, inhalation, or contact or dermal contact with contaminated water, in which case compromised water, sanitation, and hygiene, which is abbreviated WASH, is implicated. So waterborne pathogens are infectious microorganisms commonly transmitted through contaminated water and can be divided into 3 categories, including bacteria, viruses, and protozoa. A majority of these microorganisms are linked to fecal sources on land, for example, E. coli O157H7 and Cryptosporidium, just to name a few. Others occur naturally in water bodies, for example, the famous Vibrio cholerae and Legionella pneumophila. These microorganisms gain entrance into engineered water systems where they multiply to harmful levels and infect exposed individuals. Waterborne infections have been in existence for as long as man has inhabited the earth. Of note, it's been 169 years since John Snow proved that water contaminated by sewage was the cause of the 1854 London cholera epidemic. And according to the World Health Organization guidelines for drinking water quality, waterborne microbial hazards continue to be of primary concern in both the developing and developed nations.
Okay, Tabani, could you just pause the
The
slides?
invasion of novel microbes and
Okay, there we go. The slides weren't moving. So could we just restart that one, Tabani, and see if we can move the slides? Thanks.
Good morning, everyone. The title of my presentation today is Waterborne Infections and the Workplace. So the purpose of Sustainable Development Goal 6, also known as the Water Goal, as set by the United Nations in 2015, is to ensure the availability and sustainable management of water and sanitation for all by 2030, meaning we only have 7 years to achieve the 2030 agenda. It seems so far, but it's very near. My presentation today aims to remind us that we all have a role to play to achieve these SDGs, even if it is just by raising awareness on waterborne pathogen infections, how the exposures happen in workplaces, the conditions favoring microbial growth in premise plumbing systems, the complexity of the situation at hand with the focus on the built environment, and what can be done to manage these waterborne infections, and finally what NIOH is doing in this area. Please bear with me, this is a very broad topic and a crucial one too, given that blue is the new gold and I only have 10 minutes to speak. Anyway, water is essential for life but can also lead to illness when it is contaminated by disease-causing organisms. Waterborne infections are those infections resulting from the consumption, inhalation, or contact or dermal contact with contaminated water, in which case compromised water, sanitation, and hygiene, which is abbreviated WASH, is implicated. So waterborne pathogens are infectious microorganisms commonly transmitted through contaminated water and can be divided into 3 categories, including bacteria, viruses, and protozoa. A majority of these microorganisms are linked to fecal sources on land, for example, E. coli 0157H7 and Cryptosporidium, just to name a few. Others occur naturally in water bodies, for example, the famous Vibrio cholerae and Legionella pneumophila. These microorganisms gain entrance into engineered water systems where they multiply to harmful levels and infect exposed individuals. Waterborne infections have been in existence for as long as man has inhabited the earth. Of note, it's been 169 years since John Snow proved that water contaminated by sewage was the cause of the 1854 London cholera epidemic. And according to the World Health Organization guidelines for drinking water quality, waterborne microbial hazards continue to be of primary concern in both the developing and developed nations. Furthermore, the emergence of novel microbes and antimicrobial resistance pathogens pose additional challenges in waterborne infections. Workplace exposure is often an under-recognized problem. However, exposures to waterborne pathogens in these settings do occur. For example, healthcare workers working with water-related devices that generate aerosols. Critical reservoirs in these settings include emergency showers, eye wash stations, and dental unit water stations and other aerosol-generating devices. Eye wash stations and emergency showers in particular may not be used for weeks to months, and the water may stagnate at room temperature for long periods, contributing to microbial growth in those points. Sanitation workers, including wastewater treatment plant workers, septic tank and pit toilet emptiers, are also at increased risk of exposure to waterborne pathogens. Wastewater treatment plants generate copious amounts of potentially contaminated aerosols that travel for several kilometers. Additionally, accidental ingestion of sewage and wastewater splashes can also occur in those settings. Emergency relief workers, especially those involved in floods, cyclones, and tsunamis, are also at increased risk of exposure to waterborne pathogens through accidental ingestion. Laboratory personnel working with potentially contaminated water samples can be exposed as well via accidental ingestion and inhalation of aerosols if proper PPE is not worn. Agricultural workers and landscapers using alternative water sources, for example, those using treated municipal effluents, which we know as recycled water. Some use grey water and roof harvested rainwater for non-potable purposes. These workers are also at increased risk of waterborne infections. Of late, professional drivers are at an increased risk of Legionnaires' disease, which is a potentially fatal form of pneumonia. It has been reported that Legionella pneumophila has been detected in cabin air filters and windscreen wiper fluid reconstituted with water. These exposures can lead to enteric respiratory and skin infections depending on the route of exposure. Other important factors to consider are duration of exposure, the dose-response relationships, and the immune systems of the exposed individuals. This list is non-exhaustive, and because the topic is very broad, I will focus on infections in the built environment. So, what is the complexity of the situation? Yes, the situation is very complex, given that water entering a building is considered fit for intended use and safe, but however, it is not sterile because microbial hazards can arise at any point from treatment to tap or to point of use, such that the water that we receive in our buildings can contain pathogenic microorganisms, including opportunistic premise plumbing pathogens like Legionella pneumophila, Pseudomonas aeruginosa, the non-tuberculous mycobacterium, and many others, even at acceptable levels of the indicator bacteria system. In South Africa, potable water is required to meet drinking water standards, which are the South African National Standards, SANS 241, for drinking water. It is therefore the property of facility owners' responsibility to ensure that or to maintain acceptable water quality at all times. So what are the conditions that favor growth of microorganisms in our buildings, particularly those large complex buildings, such as healthcare facilities? Engineered water systems provide conditions that are suitable for microbial growth. These buildings are characterized by long networks of pipes, which encourage disinfectant loss. By the time the water reaches the point of use, there is no more disinfectant that is detected. Intermittent or reduced usage, as well as reduced occupants, characterize also these buildings, whereby stagnant water it collects in pockets of the systems. This can happen from poor daily turnover or reduced usage and demand, as what happened during COVID-19 lockdowns, when there was complete shutdown in non-essential service buildings to achieve the social distance regulations. Biofilm development is also a big issue in large complex buildings because biofilms offer a protective shield against treatment procedures. And then microorganisms tend to hide in those biofilms. Aging infrastructure, which is a big problem, particularly in developed or in the developing countries, but also an issue in developing nations. This, coupled with inadequate maintenance of the systems, can provide nutrients for bacterial growth. Poorly designed buildings is also an issue, whereby you find that some buildings just have too many fixtures and faucets. Maybe they're just trying to make room for expansion in the future. However, this just creates dead legs and pockets of stagnation, which cannot be disinfected. Cold water tanks as well that are found situated above roofs of some buildings with inadequate insulation and are poorly maintained can also become perfect incubators for potentially harmful microorganisms. So what can be done? Managing water use patterns can help reduce the risk of exposure, and this can be done by managing water turnover in the system to reduce microbial growth, as it helps to maintain low water age. This also helps in the delivery of fresh water in the building with the correct levels of disinfectants. Design considerations include installing automatic flushing devices in the buildings, or just avoiding dead ends or dead legs in the buildings. Maintenance considerations include routine manual flushing programs or remedial measures in situations where automatic flushing devices cannot be installed. However, it is important to know that flushing is site-specific and should be done by competent people following the correct procedure to avoid unintended harm. Managing distal ends can also help minimizing waterborne infections. The distal sections immediately up the point of use, for example, the tap or the shower head, has a number of unique features that are favorable to biofilm and microbial growth. These components can include the shower heads, thermostatic mixing valves, backflows valves, interconnection piping, and aerators. These components are characterized by small diameter piping and a large surface to volume ratio, which promotes stagnation issues and biofilm formation. Controlling biofilm and microbial proliferation at distal points. Important considerations to note here include water circulation can be maximized by a combination of improved design. For example, limiting the number of outlets. Too many will lead to stagnation. Preventative flushing procedures, as previously mentioned. Use of biostable materials that do not support microbial growth. And also minimizing the surface area available for biofilm growth. What do we do at NIOH? At NIOH, with regards to contributing to the fight against waterborne infections, the Waterborne Pathogen Unit at NIOH is accredited for microbiological water quality testing for drinking water, as well as treated wastewater effluents. We also respond to queries related to the microbial quality of water, and also conduct research and human capacity development in the water sector. For your take-home message today, in a post-COVID-19 world, it is important to acknowledge the hazards that waterborne infections can pose to the public, and that appropriate prevention is implemented to minimize risks. The COVID-19 pandemic taught us to be more proactive than reactive when it comes to water quality management in our buildings. We have also learned that it is important to know your system because you cannot manage what you do not measure. This way, you are not taken by surprise when there is an influx of guidance documents, because guidance documents are not a one-size-fits-all. We have also learned that endpoint testing, which we know as regular monitoring of water quality, is just a snapshot which addresses only parts of the water system, and it can give a false sense of security. Instead, total quality management and the weakest link theories should be applied, whereby water quality management systems are implemented, particularly for high-risk buildings. On-site risk assessments should be performed by competent persons, which is what we have also learned. And risks should be reviewed and control measures implemented according to the risk assessment. And lastly, beware of the first flush next time you open your tap. Thank you very much.
Thank you very much. And that was Dr. Nonsi Gomba. She's one of our senior medical scientists here in the NIOH with the immunology and microbiology section. So we've had our presentations from Professor Zungu, and we've had our presentation from Dr. Nonsi Gomba. I'm now going to immediately hand over to Professor Cheryl McCrindle, who's going to speak on occupational health and zoonotic infection. Welcome, Professor, and thank you very much for taking the time to prepare and to share your presentation with our attendees today. I hand over to you immediately if you could share your PowerPoint. Thank you.
There we are. Thank you. Can you see my PowerPoint?
Yes, if you could maximize the slide. Thanks for presentation mode.
I'm just doing that now. If you just give me a minute. Okay, so what I'd like to say to you today is Maybe I should just take my face off the screen. Can you take my face off there? Because then we can show the screen properly. What I'm showing you here today is what veterinarians do. Does anybody know what that particular veterinarian is doing with his protective clothing on? Any answers? He's busy taking the skull off, the head of the skull off a dog that has died of rabies. As you see, he's wearing rubber gloves, he's wearing a face mask. He's like this because he's going to take a shower off afterwards. We use green overalls and gumboots. That's what we do. His assistant has also got a face mask. And because if you spray any of this into your face, you're probably going to die of rabies, and there is no cure. So as veterinarians, we tend to take a lot of care about, can I go back one? Mistake. We go back to the top. Okay, so I just press once carefully. We're talking about the Occupational Health and Safety Act number 85 of 1993. Specifically, it stipulates that it is the duty of the employer to provide and maintain a work environment that is safe without any risk to the health of the workers. Inform as far as reasonably practicable and cause every employee to be conversant with the hazards, not the risks, the hazards to his or her health and safety attributed to any work he or she performs, any article or substance he or she produces, handles, processes, stores, or transports, and any plant or machinery he is required to use, as well as the necessary precautionary measures to avoid, eliminate, or mitigate risk. Risk pathways are terribly important in occupational health. You need to identify occupational hazards and calculate the risk associated with each particular hazard. To determine the health implications of the identified hazards for the employees, to assess the control measures in place, and to challenge them against the legislative requirements, and to make recommendations to the management about necessary interventions that should be implemented in order to minimize or eliminate the above mentioned hazards. And for your information, zoonotic diseases are biological hazards. So let's have a look at a little pattern that could come up with you. So let's have a look into your workplace. Is the agent present? Yes. Are humans in contact with the agent? Yes. Are those human beings susceptible people? Yes. Is the dose of agent high? Is there no diagnosis or effective treatment? And we'll end up with disease or death. This is exactly what happened at the beginning of the COVID-19 outbreak. We didn't know what to do with it. We didn't know how to stop it. This is just one disease which went all over the world. It was a pandemic. In order to prevent pandemics, we have to use what we call mitigating factors. So if you go back up to the top of the table, you will see the agent is present. Yes, you get problems. No, if you have healthy animals, safe food, and vector control, you won't have a disease, and you can stop this little ladder that lands up in disease or death right there at the first step. If you can prevent human beings making contact with the agent of disease through risk communication, education, and hygiene, you won't have a disease. If the people are not susceptible because they have been vaccinated and they have adequate nutrition and environment, you have no disease. And that's actually how we managed to stop COVID-19. There was a huge amount of activists who were going around saying, we don't want to be vaccinated. It's against our what. However, because most people were sensible and had their vaccine, we've managed to virtually stop the outbreak. We have it at the moment again going around, but it is not as severe as it was when we had a totally unvaccinated population. Then we look at the dose of the agent. Well, when we go to things like COVID virus, because everybody knows about that, COVID-19, it multiplies in the top of your nose, and every time you breathe out, sneeze or cough, you spread it all over the place, into the air, onto everything you touch. And that is one of the reasons why we had COVID outbreak, but we had mitigation because in the workplace, we immediately started disinfecting toilets and handles, and we told people to wear masks. So we interrupted the pathway. Then no diagnosis or effective treatment. When we started with COVID-19, nobody could diagnose it. We didn't know what the effective treatment is. Now we've gone to the level where we understand that this is an endothelial disease. And for those of you who are not really medical or veterinary, endothelial cells are the tiny little cells which are all along your microcapillaries. Now, the microcapillaries are the tiniest blood vessels in your whole body, and they function in your lungs to pick up oxygen. They function in your brain to make you think. And if those endothelial cells are damaged by the virus, our own body attacks the endothelial cells. It goes in there with cells called macrophages and others called lymphocytes. They release toxic substances. And I always say it's a little bit like an invading army. The macrophages come along to kill the COVID viruses. And instead of killing them, they knock down our defenses and the blood leaks out through our microcapillaries into the tissues and take some serum with. And the lymphocytes come along and say, oh, what's the serum doing in the blood vessels? We're going to release a whole lot of toxic substances to neutralize that, and all these funny things that are coming out of the blood vessels, and suddenly you have virtually what we would call an endothelial disease. It's like a little, I don't know, World War III right in your blood vessels. However, we have mastered COVID-19 because we have correct diagnosis and effective treatment, because we catch the disease earlier. And we've dropped the number of people dying in the workplace because we have effective control measures in place. So high-risk occupations for zoonotic diseases. I've got a list on the left, and on the right, there's a picture which just describes you. Anybody who works with animals, vets, pig farmers, crocodile farmers, fishing people, wildlife hunters, laboratory scientists, technicians, meat inspectors, abattoir workers, slaughtermen, dairy workers on farms and factories, workers in the food industry, including supermarkets. I noticed there are a couple of supermarkets there, and we certainly had listeriosis coming out of the supermarkets, and that is a zoonotic disease. So I've given you here a whole list of bacterial and protozoan diseases because somebody else is going to be talking about viral diseases and where to find more info. And you are going to get a copy of the slides. So I suggest that if you're interested in these, does anybody know out there, and I don't know if you can talk back to me, but that little red star with the question mark in it in the slide means, why did I put a red star under or next to certain zoonotic diseases? I don't know if anybody knows. You can put your hands up afterwards, but that red star means they're important. So there's a question here. I'm not exactly sure how to get questions answered, but I've got a picture here. I've got 1, 2, 3, 4 scenarios here. And I want you to think about for a bit, which of these scenarios is has the highest risk? I can't get answers here. I'll get them just now. I don't know if anybody wants to put their hands up. Which one is the chap hugging the tiger? The one in the middle is, Kathleen de Villiers, you've raised your hand. I don't know if you want to come on board and talk. Can you put on your microphone and say something? Well, anyway, you can send a message just now. The one in the middle is the Black Death. The one on the right-hand side is brucellosis. And the one down here was taken when I was training a group of people to do post-mortems on these chickens. And there's a very high risk of avian influenza, but they took their masks off for the photograph. However, we'd already done the post-mortem, so we knew there was no avian influenza in the chickens concerned, and this was a sterile environment, but they should have had masks on. So I'm not going to tell you the answer. I'm going to go to the next slide, which tells you the answer. And the answer is plague. Let me go back a slide. I don't know how to get backwards. Backwards. Okay, there we are. One more backwards. Which one? That one there. Okay, So the answer is poor hygiene, rats, fleas, and plague. A hazard is anything that could cause harm. Risk is a combination of two things: the likelihood that the hazard will cause harm and how serious that harm could be. So basically here, if we've got a lot of rats and a lot of rat fleas, we can have plague. I have been around when we isolated plague from one of my students in about 1994 who was working in a rural area in Northwest Province, and she picked up plague working in a very dirty environment where there were a lot of rats and a lot of rat fleas. And actually, it's possible that the rat fleas went onto goats as well. I was prevented from publishing it because this is declared a disease, and the doctor who did the isolation was prevented from publishing it. Fortunately, plague is very treatable, and she survived. But we have a very high risk. If you have a lot of rats and you don't control them in your environment, that is at work, there's always the possibility of plague. We still have plague in India, and we still have plague. There we are in the old days, the history of the three, Justinian, 18, Black Death. Here they are dumping bodies into a hole in the ground. And Hong Kong, Anglo-Boer War, 1912, sporadic till the 1950s, and I saw a case in 1994. So the multiple checks of questions are here. I'm not sure how you're supposed to answer them, but we'll just go on from there. Thank you very much.
Thank you very much. That was Professor Cheryl McCrindle. Thank you very much, Professor, for your contribution.
Thank you very much indeed.
McCrindle has dealt with the occupational health and zoonotic infections, and she raised, for example, also the one that dealt with listeriosis, which we're all very familiar with. Our next speaker is Professor Lucille Bloomberg, and she will be speaking on hemorrhagic fevers and the workplace. I'm going to hand over to you immediately, Prof, so that you could share your slides. And after that, we'll have a short Q&A session before we close the webinar.
So thanks very much, Ashraf, for the invitation. I think you're all familiar with Ebola outbreaks in West Africa, in the DRC, and high rates of infection amongst healthcare workers. On the left, you see protected healthcare workers, which happens once, in many places, once the outbreak is recognized. In the second picture, you see the Redemption Hospital, where many disasters occur because of poor infection control and the failure to recognize the first patients who come with Ebola. So in South Africa, we have two of the viral hemorrhagic fevers, and the viral hemorrhagic fevers are a very special group of viruses with high mortality rates, and for many of them, a risk of person-to-person transmission, with particular problems in transmission to healthcare workers. So in South Africa, we have Crimean Congo fever, and perhaps one that's lesser known, which is Rift Valley fever, which you see on the right. We have outbreaks every 20 years. We are due for one, so we need to be prepared. A little bit about Congo fever. We have a laboratory at the NICD, the reference laboratory for VHFs in South Africa, where we can confirm the diagnosis. And our commonest VHF is, in fact, CCHF. I think that's 133 lab confirmed cases, sorry, for the last number of years. And Congo fever is transmitted to humans from infected hyaloma ticks. Those are very pretty ticks that you find in certain parts of the country. The ticks don't like to bite humans, otherwise we'd see a lot more cases. Livestock get infected when the ticks feed on them. They have an asymptomatic viremia, but those in an occupational setting who have contact with blood and body fluids of viremic animals may contract the disease. And then the third mode of transmission is nosocomial transmission. It's very much an occupational illness, and you can see of the occupations, animal health workers, abattoir hunters, game wardens, odd tourists, the odd one involved in informal slaughter, farmers are by far at highest risk. So it's important to look very carefully at histories. And the one on the top is a typical case. This was a farm worker in the Northern Cape who presented with an acute febrile illness and 3 days later presented to bleeding and was transferred to the reference hospital, and Congo fever was confirmed. So a history of exposure, history of occupation is extremely important in the diagnosis. So during COVID, there were a lot of misdiagnoses of many diseases, mostly malaria and flu-like illness. But here is a case of CCHF that occurred in somebody who also had COVID. He was a farmer with fever, respiratory symptoms, but only when they noticed a profound thrombocytopenia and asked what he did as an occupation. And when he said he was a farmer, this prompted testing and confirmation for Congo fever, and the appropriate infection prevention control measures were applied. Of course, there's a very large differential diagnosis of fever, progressive illness, bleeding in this sort of group. And Cheryl's mentioned many of the zoonotic diseases. Tick bite fever would be particularly important. But it's important when you do get the history of fever, progressive illness, bleeding in somebody who has animal contact, that you consider Rift Valley Congo fever and some of the differentials. The man on the left is a veterinary technician, very well informed. And after he'd visited a Kroonstad farm where he'd picked ticks off a cow while attending to the animal, he developed a fever quite quickly and myalgia. He knew about Congo. He presented himself to the local hospital, told them that he thought he had Congo fever. They must isolate him and they must send blood to the NICD, where we in fact did confirm the diagnosis. Fortunately, diagnosis was made early and no secondary cases were confirmed in the hospital. The patient on the left is a slightly more unfortunate incident. He was a resident of Johannesburg. He presented to a local academic hospital with vomiting of blood, hematemesis. They thought it might be a peptic ulcer. They did ask in the history about travel, but he hadn't been anywhere outside of Johannesburg. But when they did the gastroscopy, there was nothing. And when they looked at the blood count, in fact, there was a very low platelet count. He was febrile. They went back to him, asked him what he did. And in fact, he was an abattoir worker in Johannesburg. And obviously they deal with animals from all over the country. And he'd been infected in the course of his work. I think most importantly, in stopping spread, in particularly healthcare workers, it's to recognize the possibility of a viral hemorrhagic fever early and to institute proper infection prevention and control measures. This is a famous outbreak at Tygerberg Hospital. Again, a patient came in with vomiting blood, didn't ask a proper history. He went for gastroscopy. And in the course of his stay, there were a number of needle stick injuries, 6 nurses, 1 doctor was infected, and quite late, Congo fever was confirmed. And in fact, going back, he did have contact with animals, but the history was not obtained. The Congo has quite a high mortality rate. There's no vaccine. The protection of healthcare workers is early recognition and the donning and doffing of appropriate protective clothing. It's really supportive treatment and monitoring of contacts. And that would be all healthcare workers and persons who've been exposed to the infected person for symptoms, fever, for 14 days. We don't yet have a vaccine. We do have some drugs for post-exposure prophylaxis, but of limited value. I think the key message is very good histories in any person who presents with a febrile illness, particularly if there's bleeding. Not all viral hemorrhagic fevers bleed, but if there's multi-system progressive pathology, you always have to ask, where do you live, travel history, often it's malaria, don't want to miss that. But if the occupation indicates that there's animal or patient contact, and I think Cheryl gave a very good group, you must think of a zoonosis. And amongst the differential diagnosis, you must test and take precautions against the viral hemorrhagic fevers, and in the South African setting, particularly for Congo fever. Now, Rift Valley fever, as mentioned, we may be expecting an outbreak with El Nino. The conditions are right. The disease is well described in East Africa, but we've had our outbreaks here. And in 2010, we were informed that there was an animal outbreak in the Free State, Eastern Cape, and Northern Cape. There were a number of abortions, which really prompted the consideration for a number of diseases, including Rift Valley fever. Unfortunately, there was good contact with the animal health side, who promptly called us and confirmed the outbreak in animals and that we should look for the disease on the human side. And yes, there were 242 laboratory confirmed cases and 26 deaths. The importance of knowing about the outbreak and looking for it in those who are at risk cannot be emphasized enough. It presents with a very non-specific flu-like illness, sometimes even asymptomatic presentation, or patients who are asymptomatic, and would be misdiagnosed as something unrelated, and the diagnosis of Rift Valley fever would be missed unless there is that epidemiological link with the outbreak and in those who are at risk. So that contact with animals in or from suspected Rift Valley fever areas or residents in that area presenting with a flu-like illness or any of the complications, encephalitis, bleeding, liver problems, and or ocular pathology, you have to think about a Rift Valley fever diagnosis and submit specimens. And the key is the type of occupation that somebody's involved in. It's the major transmission is exposure to infected animal tissues and blood. So again, it's that occupational risk in farm workers, animal health workers, and slaughtermen. No human-to-human transmission, as you see with many of the other viral hemorrhagic fevers. And that was one of my colleagues who's a vet. Unlike many vets, he was wearing some gloves to protect him during the necropsy, but very shortly after this picture was taken, he cut his finger with the scalpel, and he in fact contracted Rift Valley fever, but fortunately he recovered. We did look at the occupations of those who were infected during this outbreak, and you can see in at least 81%, there is a very well-defined risk of contact with animals, farmers, animal health workers, the usual group of at-risk people. And be transmitted occasionally by mosquitoes or unpasteurized milk, but in an outbreak and in a South African setting, it's the occupational risk of transmission. So how do you prevent it? There is no vaccine. The message is avoid unprotected handling of animal tissues, carcasses, aborted fetuses, through post-mortem slaughter, butchering, assistance with deliveries. These are common procedures on farms. Harvesting carcasses, it's a source of meat, very common practice on the farms, and reducing this risk is really, really difficult. You have to really work hard. You have to work together with the animal health side to inform people how they contract Rift Valley fever and some of the methods to reduce transmission. Can't provide full PPE, it's simply not possible, but you have to attempt to try and reduce the transmission, given that there is a real mortality and morbidity associated with this disease. So I'm sorry to say, but on the animal health side, infection prevention control is not always well practiced. This was a veterinarian who took blood samples from cows on a farm that had experienced a Rift Valley fever outbreak, and you can see blood everywhere. So not the way to go. There used to be a vaccine for Rift Valley fever. There isn't a human one anymore. There is an effective vaccine for animals, and occasionally we do get self-inoculation of the animal vaccine by the veterinarians or those who are vaccinating with some potential for disease. It's a live vaccine for some potential for disease in those who are vaccinating. So again, an occupational risk. This is an outbreak of Rift Valley fever that occurred at the veterinary faculty. This was a group of students and some of the teachers who were tasked with doing necropsies on a Friday on cows sent from a farm where cows had died from an unknown disease. The gloves that they'd been provided with were kind of not in a good condition, and they also used these very high pressure sprays to hose down the animals. And we had an outbreak of Rift Valley fever. It was confirmed in the animals, 6 acute cases, and fortunately, all of them progressed very well, but we could have been a bit more unlucky. So again, a risk group, just like human health workers. So just lastly, health workers always think about viral hemorrhagic fevers. This is the disastrous story of a South African nurse who cared for a patient from West Africa who came to South Africa for care for a febrile illness with jaundice. He didn't mention that he'd worked in an Ebola outbreak. That he was a healthcare worker with a fever should have prompted, consideration. She was exposed during a procedure, developed a progressive illness and died, and Ebola was confirmed retrospectively on the patient, and also confirmed as the cause of her illness. Some of you may remember this outbreak of a new viral hemorrhagic fever. Index patient was transferred to South Africa for care as a possible tick bite fever, died as tick bite fever with no confirmation. And it was only when a number of health workers became ill with a very similar illness of fever, rash, low platelets, raised liver functions, that the consideration for, could this be a viral hemorrhagic fever, became a concern. 4 out of the 5 patients died. Infection prevention control was put in place quite early, but by that time already the healthcare workers were infected. And after some good detective work and laboratory work, it was confirmed as a completely new virus, a new arenavirus never before seen, and named the Lugo virus. So I think some important messages to take home. I think COVID has changed the way that we manage personal protection, infection control in the healthcare setting. But for VHFs, it's not about masks. It's about training, good use of protective clothing, particularly gloves, putting them on safely and taking them off safely. Good histories and occupational risk, particularly for Congo and Rift, prompting testing if appropriate. And I think having good monitoring amongst healthcare workers, and if you have a previously healthy healthcare worker, or particularly a cluster of healthcare workers with acute, febrile, progressive, multi-system disease, think about these diseases, particularly viral hemorrhagic fever. Thank you very much.
Thank you. And that was Professor Lucy Bloomberg. Her particular focus is, as you've heard, on infectious diseases and microbiology specialist at the NICT. She's definitely involved in the right to care, and as I mentioned, the University of Stellenbosch and at the vet of the faculty of the University of Pretoria. Her special interest is not just travel and tropical diseases, outbreak prevention, but more importantly, I think for me, is that she has an occupational health diploma also on top of all of that from the University of Witwatersrand. Thank you very much, Prof. Bloomberg, for that. And if you could just I'm going to ask now my colleague, and if I could quickly get through all of this to my program, Dr. Edward Sipirwa, just to quickly manage our short Q&A session. We are very thankful to all of our attendees for allowing us to go slightly over time because of our earlier technical glitch with the second presentation. If you could share your, open your microphone, and Dr. Edward Sipirwa is currently a registrar registrar in occupational medicine here at the National Institute for Occupational Health, and I'm very pleased that he could take on this responsibility. And I ask him just to join us with his. I'm going to ask you, Edward, if you could just be short and brief, perhaps at least one question per speaker for those who are able to give us some quick answers. Edward, over to you.
Hello, colleagues. I'm Dr. Edward Spiro, as Ashraf has already introduced me. Actually texted you guys one of the questions that I'll be asking right now, but surely it's going to be a very simple question. I don't know if I should maybe ask per speaker, or should I just outline all the questions and then speakers will be just be responding to the questions?
Yeah, Edward, you can decide on that. Maybe just direct to each one.
Okay, let me just ask and then we'll per speaker to make it easier. So to Prof. Zungu, so obviously COVID, we understand that how it's transmitted primarily how some of this disease that has been around, like TB, has been there. The only issue is that it was a novel virus into the public health system. What are one of the key issues, or do you think workplaces need to solve or need to work towards in order to mitigate the dilemmas which we face considering business and health? So it's a matter of saving livelihoods and saving lives. You know, there's been tension between businesses and the health sector in trying to save lives, and then businesses talking about livelihoods. What are the key things in preparation for other key novel viruses that might present to the workplace, respiratory viruses per se?
Thank you, Edward. I think that for the workplace, you know, it's always to be systematic about how you deal with problems, especially when you're talking about novel issues that might not be known. So the best thing is always to be on top of your risk assessment, because that risk assessment will be able to always help you to look at what are the loopholes that you need to close in your workplace. However, one of the other important things that I referred to during the talk was that we are lacking in surveillance. Surveillance in general, in terms of occupational health, will include three parts. The first one being, medical surveillance at the workplace, but also being able to take that data and submit it somewhere so that it can contribute towards the public health surveillance in the country, so that we can have things so that we can have information to plan for the future. So without taking a lot of time, because we don't have a lot of time now, I'd say the key things is that always keep your risk assessment up to date, have a functioning surveillance system so that you can pick up problems early and then you can act on them. Thank you.
Thank you so much, Prof. Zungu. That was straightforward. So the key thing is have your risk assessment procedures at work. So to Dr. Nonsi, what has been found to be the key route of exposure to waterborne pathogens in the workplace, and what advice can be given to the workplace to mitigate this?
Thank you, Edward. Can you please repeat the question?
What has been found to be the key route of exposure to waterborne pathogens in the workplaces, like in some of the key work groups, and what can be given to workplace, what can be done in the workplaces to mitigate this?
Thank you for the question, Edward. So the route of exposure depends on the work activity that is being done. And so I would like to think that in my presentation, what tended to be most the most route of exposure was inhalation, basically because of the activities that I focused on, or the work activities that I focused on. But however, there is no like a blanket route of exposure that we can say this is the most common. It just depends on the work activity that is being done and the target microorganism that can potentially cause harm to the exposed worker, right? So the routes of exposure can be ingestion, whereby we would want to think this is accidental ingestion because no worker would ingest or consume water that they know is not safe or might potentially be contaminated. So that's accidental ingestion. And then inhalation would then apply to work activities that generate aerosols that can be inhaled and cause respiratory infections. And then this would apply to, like I said, agricultural workers. It can apply to healthcare workers, wherever there is equipment that is generating aerosols that can be inhaled. And then dermal contact as well apply generally. Yeah, so but maybe you may want to say ingestion and inhalation, but inhalation is kind of overlooked because we are used to the fecal oral route transmission, and then we tend to overlook pathogens like Legionella, pneumophila that cause potentially fatal diseases or infections. So there's no blanket like route of exposure. It just depends on your work activity, and like what Prof. Zungu has just said, the risk assessment would tell you what route of exposure you are facing in terms of the work activity that is being done. Yeah. So then, in terms of guidance that can be given, same applies. You must the facility should always have a water quality management system in place so that they are not taken by surprise and when issues arise, and they also do not are not reactive to situations, but rather proactive, which then speaks to risk assessments that are done periodically depending on your facility. I think that would, I hope that answers the question, Edward.
Okay, thank you so much. I hope colleagues have gotten from so much, because I don't want to continue with it, but at least you covered much of the areas. So, Prof. Cheryl.
Yes.
There's been an increasing concern about occupational health and safety in agriculture, right?
Yes, sir.
Which, looking at this presentation, many of these zoonotic diseases, they also emanate from such places.
Yes.
And whereas these diseases are communicable diseases, of which many of these people are usually in the peripheries, where there are issues of advanced medical care. What are some of the key moves that the veterinary public health specialists do to help mitigate this, looking from the perspective of occupational health?
Actually, quite frankly, for me, the one that is most neglected at the moment is brucellosis. We have up to 15% of abattoir workers who have got brucellosis. It makes women infertile and men infertile. I'd say that's it's not fatal. It just makes you very sick. And it, unfortunately, in women, your babies are born dead, and in men, you become permanently infertile. And there are not really any structures at the moment, and that's the one that I'm sticking my hand up for and campaigning for, that I do think that abattoir workers, people who work, and veterinarians, I mean, I know about it. I have several veterinary friends who've had the disease, and that is for me the zoonosis, which has the most debilitating effect in agriculture at the moment. So I'll just stop there. There are other diseases as well, a lot of them acute, but it's the chronic ones that people are not really taking enough care about.
Okay, thank you so much, Prof. I hope we have colleagues from departments or national departments who will have Prof in assisting with some of these diseases, because clearly you are saying that we don't have very solid structures to help prevent any of these diseases, especially with some. I know recently there's been one.
No, Sorry to interrupt. I'm not only talking about brucellosis, because brucellosis, unfortunately, when you kill a cow, you spray its blood into the air and it becomes an inhalant disease. And it's not only in South Africa that is happening. I've been to a lot of abattoirs internationally where we have exactly the same problem, because it's something when you get blood in the air and you inhale it, you get the disease. So that's the full stop on that. It can be prevented, but it's difficult and it's expensive. And that's why it's not being adequately controlled worldwide, not just in South Africa. There are other diseases as well, but I think that for me is the number one that I would concentrate on if I was able to do so.
Okay, thank you so much. And Prof. Bloomberg, these fevers, many are of viral nature, looking at the presentation that you gave us. And vaccines have been a highlight lately, especially in occupational health also. How much coverage of vaccines or vaccination programs are there, specifically in South Africa, to cover various occupations to prevent these viral hemorrhagic fevers?
So there are very few vaccines for viral hemorrhagic fevers. The Ebola vaccine, I think, is probably the best developed one. It is used to respond to outbreaks for post-exposure prophylaxis for both populations and health workers. And in those involved in an outbreak, the vaccine is administered to the formal healthcare workers. Remember, in these areas, there are many informal healthcare workers who may be exposed. For Congo fever, there is no vaccine. For Rift Valley fever, there is no commercially available vaccine. So part of the research and development program is to look at vaccines, chemotherapy, and diagnostic tests to be developed for more viral hemorrhagic fevers. But currently it's only for Ebola, and we don't have Ebola transmitted locally in this part of the world.
Okay, thank you, Prof.
Well, thank you too for that, Edward. And so thank you for handling that particular Q&A session. We are very much beyond our time, with the permission of the attendees. And that was Dr. Edward Sipirwa handling the Q&A session. And then a final thanks to our presenters, Professor Mzumkulu Zungu from the NICD and also associated with the School of Health Systems and Public Health at University of Pretoria, Dr. Nancy Gomba from our Immunology and Microbiology section, and the NIOH here, and as well as Professor Cheryl McCrindle, who is associated also with the University of Pretoria, and Professor Lucille Bloomberg, a consultant with the Right to Care here in South Africa, as well as associated in honorary capacity with the NICD and the Universities of Pretoria and Stellenbosch. And then finally, for our Q&A chair there, Dr. Edward Sipirwa, a registrar here at the National Institute for Occupational Health, Occupational Medicine section. And with that, I thank you all for your patience and indulgence and thank you for accommodating our little glitch there at the beginning that took up some of our time. And this has certainly been, I think, a most informative session for me, and it should be informing us in our workplaces as well, especially where these particular biological hazards are present, or our workers and our fellow colleagues and so on may be exposed to, and to ensure that we prevent them. You've now been informed by the specialists, highly qualified specialists, in terms of what the challenges are, and I think what are some of the things we've got to seriously consider to ensure that we keep our fellow workers protected, healthy, safe, and away from occupational diseases. That's the end of this webinar, and we look forward to seeing you in our next webinar of the National Institute of Occupational Health, a specialized division of the National Health Laboratory Services. Goodbye. Thank you.
Thank you.